Hello, everyone. My name is Mohammed Ranavaya, and I'm the Associate Dean for the Continuous Medical Education for Marshall University School of Medicine and Marshall Health Network. It is a great pleasure for us to present the series of the CME On Demand. And today we have an excellent speaker, Dr. Jennifer Henneran. She's a professor and chair of the Department of Internal Medicine at Marshall University, John C. Edwards School of Medicine. She has recently joined in July 2025 following an impressive career in academic medicine and hospital leadership. She earned her medical degree from Chicago College of Osteopathic Medicine and completed her residency and fellowship in infectious disease at Case Western Reserve University. As a distinguished clinician and educator, Dr. Henneran has held leadership positions at several major institutions, including serving as a chief of infectious diseases and medical director of infectious disease prevention. Her research and clinical expertise focus on antibiotic resistance, infectious disease management, and quality improvement, and ultimately improving the patient care and patient outcome. She has published extensively in leading peer-reviewed journals and remained deeply committed to advancing patient care and medical education. She's going to be presenting on urinary tract infection, UTI, is it or isn't it? Before I invite Dr. Henneran to present her lecture, I wanted to go through briefly the CME On Demand, which is an enduring material under ACCME, the Accreditation Council for Continuous Medical Education, that accredits Marshall University, John C. Edwards School of Medicine to provide continuing medical education for physicians. Dr. Henneran, under the rules promulgated by the Accreditation Council, has disclosed no relevant conflict of interest or relevant financial relationship with any of her presentation today. Marshall University School of Medicine, as an accredited provider by ACCME, designates this activity for 1 hour of AMA Category 1 credit, for which at the end of the presentation, I will make an announcement as to how to claim that accreditation. I should remind all of my colleagues that under the AMA policy, physicians should only claim the credit commensurate with the extent of their participation in the activity. So without further ado, it is my pleasure to invite Professor Henneran to present her topic, UTI, is it or isn't it? Please.
Okay, thank you very much, Dr. Ranavaya. I have no conflicts of interest to disclose. Okay, so today I'm going to try to give you some information to think about. Urinary tract infections are a very difficult topic. It's often very difficult to tell whether or not a patient actually has a urinary tract infection, and it's one of the most often misdiagnosed infectious diseases. So what I would like you to get out of this talk is primarily I want people to decrease unnecessary urine cultures, and I'll talk a lot more about that. I want providers to be able to identify individuals with asymptomatic bacteriuria, and also for people who practice in the inpatient setting to eliminate unnecessary urinary catheters. So I'm going to go through a couple of cases. The first one is a 75-year-old woman with a prior history of mild dementia and urinary retention. She's admitted to the hospital with pneumonia. She has an indwelling Foley catheter, and her family is concerned because the urine is cloudy. A urinalysis is sent from the emergency department that shows 10 to 30 white blood cells per high power field. It's growing greater than 10 to the 5th colony-forming units of multi-drug resistant Acinetobacter. She has improved on treatment for pneumonia, but the Acinetobacter is not being treated. So the answers could be change antibiotics to cover the multi-drug-resistant Acinetobacter, change the Foley catheter and send another urinalysis and culture, C, ignore the urine culture as the patient is getting better, or D, request an infectious diseases consult. And most often what I've seen is that there's a request for an infectious disease consult, and often people change the antibiotics to cover the multi-drug resistant Acinetobacter. The correct answer is to ignore the urine culture because the patient's getting better. So obviously this patient doesn't actually have a urinary tract infection from this organism, or she wouldn't be getting better. Okay, the second case is a 90-year-old woman who comes to the clinic for a hospital follow-up. She was hospitalized with UTI. She tells you that she has a long history of recurrent urinary tract infections and gets them very frequently. Every time she has a urine culture, she's told that she has a UTI. The bacteria have been more resistant recently, and she's asking what she can do about this. So what should you do? A, get her medical records and review all of her cultures. B, get another urine culture while you're waiting for her records. C, refer patient to ID for chronic management. And D, none of the above. And really the answer in this case is, obviously you want to review her records, but really the thing is to ask her about the symptoms that she's having. Because one of the things that we see often is that people get urine cultures when they're not having any symptoms of urinary tract infection. And when that happens, they're often told that they have a urinary tract infection when in fact they were not having symptoms. And that is actually asymptomatic bacteriuria, not urinary tract infection, and they don't require any treatment. Okay, so why does this matter? It matters for a number of reasons, but one of the big things is collateral damage. So when we give antibiotics for conditions that don't require antibiotic therapy, we cause collateral damage. So we cause injury on something other than the intended target. And this report came out in 2019, just prior to the COVID pandemic, and highlighted the threat of antibiotic resistance in the United States. During COVID, this actually got worse, and we're just now starting to get back to our previous baseline. But it turns out during COVID, of course, there was a great deal of antimicrobial overuse. And so we had huge increases in antibiotic resistance. So one of the things that happened was that even though we knew that patients were infected with the virus, they were still getting antibiotics. And this was even after the question of whether or not azithromycin helped with COVID was clearly settled. And by the way, it does not. So patients were still getting broad spectrum antibiotics when they were getting admitted to the hospital. And then we saw a big increase in multi-drug resistant bacteria. So why do we see this? One of the problems is that it's very easy now to spread infections throughout the world. So anytime that you have a multi-drug resistant organism arising anywhere in the world, it can be across the world within 24 hours. And so this shows you the flight patterns throughout the world. And in the United States, we have over 350 million travelers arriving through more than 300 points of entry. And so any resistance anywhere in the world can quickly become a problem here. Everything that we do is connected. And this graphic shows you kind of how everything is interconnected. So if you look at farms, for example, farms often use antibiotics in animal feed because it actually helps to increase fat in animals. And so these antibiotics end up in our food supply, and it increases the risk of multi-drug resistance. One of the interesting things is, if you look at this one, this gentleman with his dog, in 2009, there was a study done looking at household dogs and cats, and they looked at the prevalence of multi-drug resistant bacteria in the stool of household dogs and cats, and about 10% actually had some very high level resistance. And again, this comes from food production. Also, daycares, kids that go to daycare often get antibiotics for various reasons, and so that's another place where drug resistance comes from. One of the interesting things to me, since I've spent a lot of time in infection prevention, if you look at this healthcare worker over a hospital sink here, is that when we wash our hands in the hospital, if we have multi-drug resistant organisms on our hands, those can actually get into the pipes underneath the sink, and they've been demonstrated to stay there as long as 2 years after the source patient was in the hospital. So that's important because the multi-drug resistance is something that once it gets into our environment, it stays for a long time. And so we want to make sure that we're not inappropriately using antibiotics and contributing to this problem. We have seen big increases in multi-drug resistant Pseudomonas, extended spectrum beta-lactamase producing Enterobacteriaceae, carbapenem resistant Enterobacteriaceae, carbapenem resistant Acinetobacter, and then C. diff. C. diff is not a problem of antimicrobial resistance, but as you all know, when people are exposed to antibiotics, any antibiotic, there is an increased risk of developing Clostridioides difficile. And the costs from this, on the CDC slide, it says $1 billion in estimated attributable healthcare costs in 2017, but other studies have shown this to be as high as $2 billion. And not only is this costing us a lot, but it's actually killing patients. People over 65 are at increased risk of having recurrent C. diff, and they can have multiple recurrences, and it can lead to death. So this is a serious potential problem from antimicrobial overuse. Okay, so what is a UTI, and do you really need a urine culture? I would just say that among healthcare acquired infections, urinary tract infections are one of the most common types. Most are due to catheters, stents, procedures that are done. And it's estimated that there's about 900,000 catheter-associated urinary tract infections annually in the United States. But I would just caution you that that data is really old, and I think that number is actually quite a bit higher. We sometimes think of urinary tract infections as somewhat benign, but they can lead to serious complications, including bacteremia, prostatitis, epididymitis, pyelonephritis. People can even get endocarditis and vertebral osteomyelitis. And of course, people can die from serious urinary tract infections. So when we put catheters in patients, it's important to note that that catheter is a foreign body. It becomes colonized with bacteria. A biofilm develops around the catheter. And so what happens is that that biofilm traps bacteria. And for every day that that catheter is in place, there will be a 3 to 7% incidence of bacteriuria. And so if you extrapolate that over the period of a month, 100% of people who've had a Foley catheter in for a month will have a positive culture. They will have bacteriuria. 10 to 20% of those with bacteriuria will eventually develop infection. And 1 to 4% of those with bacteriuria can actually have bloodstream infection. And so this is probably one of the most important points. When we put catheters in people who don't need them, we are putting them at risk for serious infections. Now, it's important to mention that asymptomatic bacteriuria, so having a positive urine culture in the absence of symptoms, is not a urinary tract infection. And this is probably the most important point. If you take absolutely nothing else away from this, this is what I want you to understand. If a patient is not having symptoms of urinary tract infection, but they have a positive urine culture, then there are only 2 instances in which you're going to treat that bacteria. So just to go over UTI definitions, so cystitis, simple cystitis is basically that patients have symptoms of lower urinary tract infection, including frequency, urgency, dysuria, and they may have hematuria. Pyelonephritis, people don't have to have symptoms of cystitis. They can have fever, they may have flank pain, and they, again, may not necessarily have dysuria. Catheter-associated UTI is basically symptoms are the same as for cystitis. And then we used to differentiate between complicated and uncomplicated urinary tract infection. Complicated UTI just means that there can be extenuating circumstances, and the definition of this has recently changed, which I'll show you in a moment. I just want to mention that catheter-associated urinary tract infection has a very specific definition according to NHSN, and basically the patient has to have had an indwelling catheter that has been removed in the last 48 hours. Now, one important point is that pyuria, so white blood cells in the urine, is not diagnostic of urinary tract infection. The number of white blood cells does not help differentiate asymptomatic bacteriuria from urinary tract infection. However, if you have someone who does not have white blood cells in the urine, it makes urinary tract infection unlikely. And I should say, the absence of pyuria in someone who is not neutropenic. So in people who are profoundly neutropenic, they may not have pyuria. If they have symptoms of a urinary tract infection and they have a positive culture, that's a different situation. But in most cases, if there are no white blood cells, then urinary tract infection is unlikely. But you cannot use the white blood cells in the urine to determine whether or not the patient has an infection. Now, one of the things that happens often is that people get urine cultures that are completely unnecessary. So the specific reasons to get a urine culture are when people have symptoms. So symptoms include flank pain or costovertebral angle tenderness, acute hematuria, new pelvic discomfort, new onset or worsening sepsis without evidence of another source on history, physical exam, or lab testing. There will be patients who have fever and change in mental status without evidence of another source on history, exam, or lab testing. Or you may have patients with spinal cord injuries where it's very difficult to tell. And so in people with spinal cord injuries, you have to ask a lot of questions. And sometimes people with spinal cord injuries who have autonomic dysreflexia will be told that when they develop increased spasticity, that can be due to urinary tract infections. And one of the reasons they're told this is because if they get a urine culture and it's positive, then they're told that this is due to urinary tract infection. It's difficult to tell. And I will just say that even as an experienced infectious disease clinician, it can be difficult for me to tell whether or not those patients have urinary tract infections. But in general, if a patient can actually answer questions, then you need to ask them whether or not they're having symptoms. If they're not having symptoms, then I would not get a urine culture. So some of the things I've heard as frequent reasons for getting urine cultures include that the urine smells bad, or that it looks cloudy, or that it has sediment. Patients sometimes get pan-cultured if they have sepsis, or sometimes people come into the emergency department and I've heard urine referred to as the fifth vital sign. And sometimes hospitals or laboratories will do reflex urine cultures based on urinalysis results. And this has actually been demonstrated to lead to antibiotic overuse. So those are not good reasons for getting urine cultures. Urine that is sitting in a Foley bag or in a catheter can have a lot of sediment. And also urine can smell bad depending on what someone has eaten. So that doesn't necessarily mean that there's anything wrong. There was a very interesting study that was done at Cleveland Clinic where they decided that they were just going to stop sending urine cultures in the ICU unless they had specific agreed upon criteria. So each intensive care unit decided on their own criteria, and they had to have an attending physician sign off on the urine cultures. And what they saw over time was a huge decrease in the the so-called catheter-associated urinary tract infection. And what actually happened was there was no change in mortality or morbidity. So there was no change in outcome. But basically what they learned was that they had been calling things catheter-associated urinary tract infections based on culture results. And when they just stopped culturing, they had a big decrease in the number of so-called infections. And I should mention that this type of study has been done elsewhere and has been demonstrated a number of times. So again, it's important to identify asymptomatic bacteriuria because when physicians are presented with a positive culture, they often feel compelled to treat the culture, not go back necessarily and look at the patient and figure out if the patient is having symptoms. And that drives inappropriate antimicrobial use, which increases antimicrobial resistance in the community as well as in the individual who's treated. It turns out that when we treat people inappropriately with broad spectrum antibiotics, they actually have an increased risk of sepsis later on. So the most important intervention we can do is to make sure that we're sending urine cultures when they're actually necessary, not just because there's some change in the appearance or because the urine smells bad, or just because somebody came into the emergency department for an unrelated reason. So I won't talk a lot more about asymptomatic bacteriuria, but I just want to mention it's very common. If you take adults who are sexually active, patients with spinal cord injury, people with diabetes, and people on hemodialysis who may not have the same amount of urine production, they will frequently have bacteriuria. And again, it doesn't mean that they have an infection. Also, when we give antibiotics to reduce asymptomatic bacteriuria, it actually does not decrease the risk for subsequent symptomatic urinary tract infection. All right, so for people who are found to have asymptomatic bacteriuria, I mentioned earlier that there are two situations where you would treat this. One is in pregnant women, and they should be treated for 4 to 7 days. And the reason for this is because they are at increased risk for preterm labor and for other complications. And so because of that, people with asymptomatic bacteriuria who are pregnant should be treated. And then people who are going to have a urologic procedure where mucosal bleeding is anticipated should be treated with an antibiotic prior to the procedure. So they can get 1 to 2 doses, basically prior to and maybe during the procedure, but they do not need prolonged treatment. And in all other situations, treatment of asymptomatic bacteriuria is not necessary. All right, I'm going to talk just quickly about catheter-associated urinary tract infections. There was an update published by the Society for Healthcare Epidemiology of America in 2014 on strategies to prevent catheter urinary tract infection. And the single most important modifiable risk factor is just don't use the catheter. So that's the most important thing. Only use the catheters when it's absolutely necessary. And the catheters should be inserted with aseptic technique. There should be maintenance of a closed drainage system. There should be unobstructed urine flow, and only properly trained people should be inserting and maintaining catheters. And then the catheters should come out as quickly as possible. So as soon as they're no longer needed, they should be coming out. The main indications for putting in a catheter are if the patient has acute urinary retention or bladder outlet obstruction, a need for accurate measurement of urinary output in critically ill patients. And just to clarify that a little bit further, that does not mean everybody who's in an intensive care unit needs a Foley catheter. What it means is that if you're adjusting medications based on urine output, so these are, continuous drips. So vasopressors or, medications being given specifically for to increase urine output. that qualifies. So it doesn't mean that everybody who goes on furosemide needs to have a Foley catheter. So it really is just if you have medications that you are following, the urine output minute to minute. And then for perioperative situations, for patients who are undergoing urologic surgery or other surgery on contiguous structures of the genitourinary tract, if there's an anticipated prolonged duration of surgery, patients who are receiving large volume infusions or diuretics during surgery, and the need for intraoperative monitoring of urinary output. Also, for people who have stage 3 or 4 sacral or perineal wounds who are incontinent, so if the wound is continuously getting contaminated, that would be a reason for an indwelling catheter. And then patients who require prolonged immobilization for like multiple trauma or unstable pelvic fractures or spine fractures. And then finally, for people who are comfort care to improve comfort at the end of life. Those are the reasons. So we see a lot of patients who come into the hospital who get urine catheters placed who do not fit any of these criteria. And in those situations, the urinary catheters should be avoided. One of the things that's interesting is that physicians often don't even know if their patients have catheters in place. There was this study done quite a while ago, but this still holds true, maybe more so now than even in 2000. It basically showed that the higher the level of training, the greater the unawareness of the presence of the catheter. So we have to train ourselves to go in when we see patients and notice whether or not they have Foley catheters in place. And we should actually be trying to find out, do they need to have a catheter? And if they don't need to have the catheter, we should be removing it. All right, so I mentioned earlier that the definition of complicated versus uncomplicated urinary tract infection has changed, and it has been simplified. So it's this. Basically, an uncomplicated UTI is an infection confined to the bladder in men or women who are afebrile. So it's really simple cystitis, and it doesn't matter if the person is male or female. It used to be that men were automatically considered complicated, but it turns out that the length of treatment is the same for men and women, and men can have uncomplicated cystitis. Complicated urinary tract infection is an infection that extends beyond the bladder. So that means that any infection involving the kidneys or upper urinary tract obviously are going to be considered complicated. If they have fever, if they're bacteremic, if it's catheter associated, or if they have prostatitis, those things are considered complicated. And these guidelines that just recently were published in July, they go over this. They give some new recommendations on treatment, but basically the main message I wanted to give you from this is that complicated means outside, it includes outside of the bladder. Uncomplicated means it's confined to the bladder. Shorter courses of therapy have been found to be effective in men and women with urinary tract infection if it's simple cystitis. 3 days of antibiotic therapy is sufficient for women with cystitis. And then 7 days of antibiotic therapy is often recommended for catheter-associated urinary tract infection. But if they have prompt resolution of symptoms, you can often treat for 3 days or possibly 5 days. It really depends on the resolution of the symptoms. All right, this was a study just showing that prolonged treatment in men for urinary tract infections, so 14 days versus 7 days, people actually had better outcomes when they had shorter courses of treatment. Okay, the recommendation for treatment of women with uncomplicated cystitis is nitrofurantoin, 100 milligrams twice daily for 5 days, trimethoprim sulfamethoxazole twice daily for 3 days, And that should be avoided if local antimicrobial resistance exceeds 20% or if the patient has had trimethoprim sulfa in the last 3 months. Fosfomycin 3 grams can be given as a single dose. This does have lower efficacy than other drugs, but it has the advantage of not being systemically absorbed. And all of these are to be avoided if early pyelonephritis is suspected or if you're dealing with a complicated urinary tract infection. All right, we talked about collateral damage, so I'm going to skip this except to say that antibiotics that don't have systemic absorption or antibiotics that have less effect on fecal flora, like fosfomycin and nitrofurantoin, cause less collateral damage. All right. Fosfomycin is a phosphoric acid derivative that inhibits cell synthesis. For uncomplicated acute cystitis, it can be given 3 grams for a single dose. It's a powder packet that's dissolved in 8 ounces of water. And then for complicated urinary tract infection, and this is an off-label use, so for multi-drug resistant organisms, we sometimes use 3 grams every 2 to 3 days for 3 doses. And that sometimes works, and it can avoid the need for intravenous antibiotic therapy. But I would only do this in somebody who's otherwise clinically stable. It costs around $90 per dose, and so it requires prior authorization, and insurance companies often will not approve this. And so that is one problem with this medication. All right, for pyelonephritis, the treatment is usually a once daily oral fluoroquinolone, which can be ciprofloxacin given 1,000 milligrams extended release once daily for 7 days, or it can be levofloxacin 750 milligrams for 5 days. That's an appropriate choice for patients who are clinically stable, not requiring hospitalization, and where the resistance of community uropathogens is known not to exceed 10%. So you need to know what your local antibiogram is. If the fluoroquinolone resistance is more than 10%, then it would be appropriate to give an initial one-time dose of an intravenous long-acting parenteral antimicrobial such as ceftriaxone, or a consolidated 24-hour dose of an aminoglycoside, just 1 dose. And then they could get an oral antibiotic agent after that. All right. For treatment of catheter-associated urinary tract infections, you should not start empiric treatment prior to obtaining a urine culture. If the catheter has been in place more than 2 weeks at the onset of symptoms, it should be replaced, both to hasten symptom resolution and decrease the likelihood of recurrence, and to obtain a urine culture that is not grossly contaminated. And then if the catheter can be discontinued, that is optimal. For people who have complicated urinary tract infections, if there's a perinephric abscess, so if it's greater than 5 centimeters, it will need drainage. If it's less than 3 centimeters, it will respond to antibiotic therapy alone. And if it's 3 to 5 centimeters, it may respond to antibiotic therapy or it may need drainage. These are often treated with 2 to 3 weeks of antibiotic therapy based on response. So you need to do follow-up imaging to see if there's resolution. And recognize also that if you have Staph aureus in the urine, it could be a manifestation of bacteremia or endocarditis. And so you should look a little further. When I was training, I was taught that anytime you had Staph aureus in the urine, it meant that there was bacteremia. That is not the case anymore. We do see Staph aureus as a cause of urinary tract infection, but you should pay attention as to whether there could be an underlying infection. If patients have emphysematous pyelonephritis or xanthogranulomatous pyelonephritis, they may need surgery, and they often need longer courses of antimicrobial therapy. I would definitely involve urology and infectious disease if you're dealing with this situation. And then for people with complicated urinary tract infections, they may need longer courses of antimicrobial therapy. And if there are indwelling items that can be removed, that helps to clear the infection. All right, the most important thing is don't treat the culture results, treat the patient. Anytime you get a culture result back, always ask yourself, why was the culture sent to begin with? If the patient has improved and was not getting antibiotics effective for the culture in question, generally you can just disregard the culture. And so with very few exceptions, a positive urine culture alone is not an indication of infection. And maybe the one exception is if you isolate Mycobacterium tuberculosis from a urine culture. And that's not something that you're going to get on a routine bacterial culture. Use oral antibiotics anytime you can rather than IV. There's less of an effect on the microbiome. And so if the patient has a serious infection or if their GI tract is not functioning, then IV is preferred. Otherwise, oral antibiotics are just as effective. And we have many antibiotics that have excellent bioavailability. I want to say a few words about recurrent urinary tract infections. This is a very common reason for referral to infectious diseases. Postmenopausal women are often given the diagnosis of recurrent urinary tract infections. And in fact, we often see these patients in the hospital as well. And many of the symptoms of genitourinary syndrome of menopause are actually very similar to urinary tract infection. And so it can be difficult to differentiate. And sometimes women who have genitourinary syndrome of menopause are told that they're having recurrent UTIs. And the problem is that genitourinary syndrome of menopause actually increases the risk of UTI. So they often actually have both. But the most important thing is that when you treat the genitourinary syndrome of menopause, you decrease the frequency of urinary tract infections. Okay, so this guideline from the American Urological Association just came out this year. And one of the things that they mention is that there hasn't really been consensus on the definition of symptoms. But genitourinary syndrome of menopause often includes symptoms of urinary urgency, frequency, dysuria, and as I mentioned, they can have recurrent urinary tract infections. And one of the reasons this happens is because the lack of estrogen causes thinning of the skin and the tissues in the perineum, and that can lead to urinary tract infections. And it can just lead to discomfort. And so one of the things that's recommended in that guideline is that in patients with genitourinary syndrome of menopause and recurrent urinary tract infections, clinicians should recommend low-dose vaginal estrogen to reduce the risk for future urinary tract infections. This is something that is greatly underutilized and can make a really big difference in our patients. So for women who have recurrent urinary tract infections who are postmenopausal, they should be getting low-dose vaginal estrogen. It can be applied topically or intravaginally. And one of the reasons that people sometimes are worried about using hormonal therapy is because of the thought that there's an increased risk of cancer. It's really important to note that there is no evidence linking topical estrogen therapy to the development of breast or endometrial cancer. All right, and then I just want to mention that there is an older guideline from the American Urological Association and Canadian Urological Association that also recommended that in peri and postmenopausal women with recurrent urinary tract infections, that vaginal estrogen therapy should be given to reduce the risk of future UTIs if there's no contraindication to estrogen therapy. And the only contraindication to topical estrogen therapy is allergy, and I've never heard of anyone having allergy to this. So anyway, this is one of the things that you can do to reduce the risk for recurrent infection. All right. I'm going to talk just a couple of minutes about candiduria because we see a lot of patients getting treatment for fungal urinary tract infections. So all right, so here's another case. A 45-year-old diabetic woman is admitted to the ICU with diabetic ketoacidosis. A Foley catheter is placed in the emergency department. On day 3, she's transferred to the medical floor and a urine culture is obtained on admission that is growing Candida glabrata. This now has a new name. It's Nicasiomyces, or you may know it as Candida glabrata, which was the second name. What should you do with this? All right, so the answers are: 1, treat with fluconazole. 2, remove the Foley catheter and repeat the culture. 3, remove the Foley catheter and assess for symptoms. And 4, assume that she has invasive candidiasis because she had diabetic ketoacidosis and treat with amphotericin B. Okay, hopefully you now know that this is the answer. Remove the Foley catheter and assess for symptoms. So fungi in the urine, usually it's Candida most often. Candida species colonize the genital tract, GI tract, and skin, and they're commonly present in urine cultures, especially when people have chronic Foleys. Invasive infection is very uncommon, especially in the absence of instrumentation or obstruction. And so candiduria most often does not require treatment. Now, a few things I want to mention. So Nicasiomyces or Candida glabrata is usually fluconazole resistant. And then you have to look at the different types of Candida, tell what kind of resistance you're dealing with. I would just say if you're dealing with a fungal urinary tract infection, especially if it's complicated, please involve infectious diseases. All right, asymptomatic candiduria is common. Treatment is not recommended. Again, it's like asymptomatic bacteriuria, and even in the setting of neutropenia, it's basically only if the patients have invasive infection. So patients who have urinary tract infections often have underlying kidney stones. And it's important that we also talk to people about what they can do to prevent recurrence of kidney stones, as this can lead to infection. So basically, when urine is concentrated, it allows crystallization of calcium phosphate, calcium oxalate, and uric acid crystals in urine. When the urine volume is less than 500 milliliters daily, crystallization is likely. When the urine volume is greater than 3 liters, crystallization is very unlikely. Some of the things that can increase the risk of kidney stones include soft drinks because they have fructose and sucrose and phosphoric acid, and other beverages such as tea that can increase oxalic acid exposure also can increase the risk of kidney stones. The easiest way to decrease kidney stones is just to increase water. Also, diet plays a role. So if there's excess protein from animal sources, that can increase calcium oxalate, leading to potential increases in kidney stones. If there's excess purines from animal proteins, that increases uric acid in the diet and can lead to stone formation. And then increase in salt leads to an increase in calcium, which also increases the risk. Fruits and vegetables have a protective effect against stone formation. They're good for us anyway, and we should be really promoting fruit and vegetable intake. All right. So the main things that I want you to take away from this are, if the patient has a Foley catheter, really think about whether or not they need it and whether it can be removed. Many urine cultures represent asymptomatic bacteriuria rather than urinary tract infection. If you're giving antibiotic therapy, give the shortest course possible and try to use antibiotics that have less systemic effects. And then also, if you have a woman who has recurrent urinary tract infections, please recommend topical vaginal estrogen therapy. All right, thank you.
Thank you very much, Dr. Hanrahan. So we learned quite a bit about the urinary tract infection, how to diagnose it, what it is in terms of treatment, the modern recommendation. So I would briefly ask you a few questions and see if you could answer it for our audience. So the first question I have is, why is getting a urine culture important when it is not necessarily a problem?
Well, so getting a urine culture when it's not necessary is a problem because physicians often have difficulty ignoring the culture results. So they may get a culture result that says a multi-drug resistant organism, and sometimes the way that it's reported leads people to believe that this is causing an invasive infection, and it looks bad, and it makes them worried that their patient is at risk for something bad, or they just assume that if there's a positive culture, then that means that there is an infection present. And so patients end up getting antibiotic therapy that they don't need. So if we don't need the urine culture, If the patient's not having symptoms and we're not going to do anything with that information, then we shouldn't be getting the urine culture to begin with.
Thank you. You mentioned about genitourinary syndrome of menopause. Frankly, I didn't know about that, so thank you for educating us. Why don't providers know about that?
Yeah, it's one of the I have to say it's one of the frustrations of being a woman, that medicine has ignored menopause for a very long time, and I think it's only recently menopause has become an industry that that they've realized online. There's lots of different treatment, and there's a lot of social media postings about this, and so it's gotten more attention recently. But it is shocking to realize that all of these changes that happen after menopause often cause a lot of discomfort. And women often don't talk about this to their providers because they just assume that it's kind of a normal frustration that they have to deal with, and that there is not really anything that can be done about it. And this guideline just came out this year. So it's an under-recognized problem, and it's something we should be talking to our postmenopausal patients about, especially if they're being diagnosed with recurrent urinary tract infections.
So you made a very good point. One of the things that we strive to do through our continuous education is to improve the physician competence and their performance, and ultimately the patient outcome. So I think it's a very critical point for a large population in terms of the outcome. Would you be recommending that we should also discuss this with our patients, particularly primary care physicians should be more aware of it, and that they should have this conversation? Recently, I was reading an article on Medscape about male sexuality. And you're right, women's sexuality has been largely ignored in the past decade or even years. So it's important, if it is important to talk about male sexuality, should it be part of a primary care conversation with our patients?
Absolutely. If you look at data in the medical literature, it says that something like 50% of postmenopausal women are thought to have genitourinary syndrome. And when I read that, I have to say, really, like, what's going on with the other 50%? And I think that it's underreported. I mean, there may be some women who are asymptomatic, but I would say that the vast majority of women who go through menopause have some symptoms. And so I think this is absolutely something that we should be discussing. We should be educating not just primary care physicians, but also subspecialists about this, because it affects so many areas of medicine. And, just the fact that I'm an infectious disease physician talking about this, it's because it can cause recurrent urinary tract infections, and that can cause serious problems for people. So I think it's important for physicians in general to be educated about this.
Yeah, I'm glad that you dispelled the myth about use of topical steroid, intravaginal topical steroid, because it sounds to me from your teaching that it is a very important part of the therapy. And I know many women that would be, based on their own reading or thinking, would be unnecessarily worried about use of topical estrogen.
Yeah, topical. So, there's a lot behind this. I think, the Women's Health Initiative study that was published, more than 20 years ago, I will just say, I think it did a great disservice to women, because it stopped people from prescribing hormone therapy to postmenopausal women. And the problem with that is that we now know that estrogen actually has huge effects, and in a lot of different areas, including the fact that, women who are not getting hormone replacement therapy have an increased risk of dementia. So this is an area that has recently had a lot of discussion. And, the important thing is that topical estrogen therapy is not the same as systemic therapy. And there is no contraindication to it. And so there are some people that should not take systemic hormonal therapy, but there should be a discussion with their providers about that. And there's relatively few people that have contraindications. But specifically for topical estrogen therapy, there is no contraindication.
Thank you. What do you think about urine PCR tests in place of urine culture?
I'm really glad you asked that, because I think that is one of the worst things that has come on the scene. So urine PCR tests, there are these panels of tests that can be done, and they often demonstrate multiple organisms, and they may demonstrate some resistance. But the problem is that just because an organism is there doesn't mean that it's causing an infection. And so I never know what to do with these results. And sometimes I have patients sent to me who've had these tests done, and it shows a variety of enteric flora, and it doesn't quantitate it in any way. And so it's really kind of meaningless. And I don't think we should be, this is an area where I don't think PCR testing is particularly useful. There's a lot of areas in infectious disease where it is useful, but in the urinary tract, I have yet to see a reason for doing this.
Okay. Long time ago, when I went to medical school in residency, I was taught that a combination of white blood cells, leukocyte esterase, and nitrites were accurate predictor of UTI. Is this not the case?
This is not the case, which is unfortunate, because a lot of people have been taught this, and it's really difficult to change people's minds about this. And so the problem is that if somebody has concentrated urine, then you may have an increase in, the number of white blood cells. There is no combination of factors that tells us with certainty that somebody has a urinary tract infection. Really, the single most important thing is to look at to talk to them and find out what their symptoms are. So other than symptoms, I can't give you any one thing that is going to tell me whether or not they have a urinary tract infection. Now, this can be difficult in people who have altered mental status or who are in the hospital, or people who have spinal cord injuries who are in the hospital. It's difficult to tell. But you have to ask a lot of questions about what was going on. And, I would just say the main thing is that if a patient can give you a history, talk to them, ask them what their symptoms are. And I've had some patients who tell me, oh, I never have symptoms when I have a urinary tract infection. And then I ask follow-up questions. And what I often find out is that they just have had a lot of urine cultures done, even though they didn't have any symptoms. And then they were told that they had a urinary tract infection. And so most of the time, when people have urinary tract infections, there are symptoms.
Thank you. Final question. What are some of the most important points, or the single important point you want us to take away from your presentation?
Yeah. When you get a positive urine culture result, please go back and find out what's going on with the patient. So if the patient's not having any symptoms, ignore that urine culture. That's probably the single most important thing. Maybe also don't get a urine culture unless you have a reason to get a urine culture.
Great. Thank you so very much for your time. And we do appreciate your presentation. And we hope that this will increase the knowledge, skills, abilities, performance of our clinicians, our colleagues in not only our institutions, but other regions where folks are watching this, and ultimately the patient outcome. Once again, thank you. So to receive CME credit for this presentation in accordance with the ACCME accreditation standards, you must complete the evaluation form. There is a evaluation form that will be available in the next slide, which is a QR code. To complete your evaluation, scan the QR code with your phone, or click on the link under the QR code to access the evaluation form. Once again, remind you the AMA's policy of ethics, that physicians should only claim credit commensurate with the extent of their participation in this activity. And also, this content has been developed in compliance with the ACCME's standards for integrity and independence in accredited continuing education, ensuring it is free from commercial bias. Once again, thank you all for your participation, and we look forward to seeing you in another one of these CME On Demand series from Marshall Health Network.